Her research interests include the pathogenesis and therapies of steroid-sensitive and resistant nephrotic syndrome, and she has played an instrumental role in formulating the IAP guidelines on nephrotic syndrome. She also has interest in atypical HUS, and I can tell you that we have consulted from US, on a couple of cases which we had difficulties managing, and it has been a great collaboration. And she is a world-renowned expert in atypical HUS. She has had multiple publications in peer-reviewed journals, and she has published multiple book chapters as well. She has received awards. Her most important award is the Dr. H.B. Dingley Memorial Award, which is the Indian Council for Medical Research for research in pediatrics in 2018. She has also been a Commonwealth Medical Fellow in Manchester, United Kingdom in 2018. She was a junior representative for the IPNA Council from 2014 to 2017. And she is also the current office bearer. She's the secretary for the Indian Society of Pediatric Nephrology. Aditi, it has been a pleasure knowing you all over these years, and I welcome you to moderate the session. I think Dr. Aditi is trying to re-log in. She was with us, but it looks like she had some technical difficulty and she had to move out. So I would continue with the introduction for our speaker today. And we have a special expert here, Dr. Detlef Bockenhauer, who is affiliated to Gosh Children's Gosh Hospital in London. And he has interest in renal diseases, renal diseases, tubular diseases, and electrolyte abnormalities. His articles we have been reading for a while, and he has published more than 130 original research papers, reviews, editorial boards, textbook chapters, and has published in Handbook of Pediatric Nephrology. He has been associate and subsequent deputy editor for Nephrology Nephron Physiology Journal from 2007 to 2013. It has been a pleasure, Dr. Detlef, that you could join us, and we are honored, and over to you for your talk.
Yes, thank you very much. Let me just see if I can share my screen now. Okay, so thank you very much for inviting me, and it's always a pleasure to talk about tubular disorders, which obviously is my primary interest. So when we talk about the functions of the kidney, well, usually the first thing that comes to mind is the elimination of waste products. If we are on the ward and somebody asks what's the kidney function, they usually mean what's the creatinine and what's the GFR. But there's more to kidney function than just getting rid of waste products. And another key aspect, of course, is homeostasis. And that's where our tubules come in. And then I'm not going to talk about endocrine functions like renin, EPO, and so on, 1-alpha hydroxylation, but just to summarize all the different functions that our kidneys have. But again, usually when we talk about kidney function, what we think about is elimination of waste products. And I think that's beautifully illustrated in this slide here from Kidney Research UK, which is a research charity for nephrology in Great Britain. And patients can go on this website and try to understand kidney function. And then they will come to this slide here. And you can see how the dirty blood is going into these kidneys, and then it comes to these super filters that clean the blood so that all the waste products come out here and leave in the ureter, and the beautiful clean blue blood goes back into the system. So nothing about tubules here, it's all about glomeruli. And nephrologists, like all humans, are tribal people, so we typically split up in those that worship the glomerulus, the glomerular tribe. And if you belong to that tribe, then of course, this is your favorite cell type here, the podocyte. And you talk about the glomerular filtration membrane here with the podocytes, the basement membrane and the endocytes, and perhaps even about the molecular aspects here that typically are associated with nephrotic syndrome if they break. But if you belong to the tubular tribe, and most of you, I suppose, will belong to that since you are listening to a tubular seminar here, and obviously I belong to this tubular tribe, then these super filters are only really just a small part of this larger structure called the nephron. And for the tubular tribe, these super filters are actually super stupid, because all they do is they throw out enormous quantities of bath water. And it literally is bath water. It's the extracellular fluid. It's the fluid that bathes your cells. And in that bath water are, of course, lots of precious little babies. So if you think about a normal GFR being 100 mLs per minute, that means 6 liters an hour. That means roughly 150 liters per day. So 150 liters of bath water is being thrown out by these super filters. And it contains the equivalent of more than a kilogram of salt. It contains hundreds of grams of sugars, amino acids, small proteins, and it's all just thrown out there. And who needs to clean it all up? Well, it's our tubules, of course. So without our tubules, who would reabsorb almost all of those substances that the super filters just throw out, we would have to drink 150 liters a day, because we would be peeing 150 liters a day. We would have to eat more than a kilogram of salt each day to keep up with the urinary losses, plus all the other little babies that are in there. So this is a slide from a music group of when I was young, and I'm not trying to advertise my musical taste here. I'm just trying to give you an idea of how life would be without our tubules, how this seminar would look like without our tubules. If you're peeing 150 liters per day, average bladder volume is half a liter, you would have to go to the toilet 300 times a day. So a seminar like this would only be possible here, like Ian Dury and his band on the toilet. So message of this slide is our tubules are a reason to be cheerful. And if you think about it, this is really a very strange way for our kidneys to clean our blood. Think how you get rid of waste products in your house. I mean, you typically just put it in the bin, and then you put out the bin at the end of the collection period, every week or every fortnight or whatever the collection period is where you live, and that's it. Easy, simple, taken care of. If you're a kidney, what you would do is you would take a giant fire hose and flush out everything that's in your house, everything that's small enough to fit through the window and the door. That would be the pore size of the glomerular filter. So the big wardrobe and the sofa stays in, but everything else, your books, your crockery, your cutlery, your plants, it's all flushed out into the front lawn. And then you employ an army of highly specialized robots that would be the tubular transporters. And there would be one robot that picks up the cups, and another robot that picks up the books, and another robot that picks up the forks, and so on. And they bring it all back into the house, all that's just been flushed out, making sure everything is in the right place, in the right number. So at the end of this incredibly laborious process, there is then just the empty yogurt cup, the banana peel, the mango pit, the old newspaper that's left out in the front lawn, but everything else is brought back inside. So this is an incredibly laborious and complicated process to get rid of waste products. And if you think about it, it certainly doesn't sound like intelligent design. But one of the advantages of that, obviously, is that it helps us to make sure that everything is in the right place, in the right number, and that's what we call homeostasis. And here would be just an overview of some of these transporters that are involved in there, or the highly specialized robots that are called, that I've called it before. So that what here is the, for instance, sodium glucose transporter that would pick up the sodium and the sugar together, or sodium hydrogen exchanger, and so on and so on. And of course, if any of these transporters is broken, then you will get a very particular abnormality in your urine and blood parameters that can tell you usually where the problem is. Think about it: if the robot let's picking up the knives is broken, then you will have a lot more knives in your front lawn, in your urine, and you will have a lot less knives in your house, which would be your extracellular fluid in your blood. So you get these specific abnormalities. And one of my interest, of course, is tubular disorders. And I have this highly specialized tubular clinic every Tuesday morning. And this would be me in this clinic where I'm trying to look at urine and blood parameters and then try to figure out which of these highly specialized robots, which of these transporters is broken. And when you do that, then this would be my typical Tuesday afternoon after the clinic, because it's the tubules that provide the homeostasis. And if that's broken, then there will be a lot of abnormal electrolytes. So every Tuesday afternoon, I get a lot of calls, and it's typically about potassium. For instance, here, potassium is 1.8. And these are the so-called panic results, where the lab is instructed to call the clinician directly because they're so dramatically abnormal that they feel it would be unsafe to let that, just put that in the computer and let's wait and see until the clinician picks it up. So when you do tubular disorders, when you do a tubular clinic, you get a lot of these panic calls. And this would be for me typically on a Tuesday afternoon. And that, of course, again, has to do with this idea that your tubules provide homeostasis. Life initially evolved in the ocean, and there you had a certain concentration of electrolytes. And that our excitable cells, like neurons, like muscle cells, can function is only possible because there is this certain concentration of electrolytes on the outside and a different concentration of the electrolytes on the inside, which can then be used to open the sodium channel, depolarize the cell, open potassium channels, repolarize the cells, and so on. When life moved on to land, this was really only possible because we evolved ever more powerful tubules that maintained this ancient ocean environment within us, that helped our cells to continue to function so that a neuron can still fire and a muscle cell can still contract. And if our tubules are broken, then there can be serious abnormalities in this internal milieu, as it's also called, and that lead to these panic calls. So this would be a bell curve, very normal bell curve, and this is how normal electrolytes are defined. You take 1,000, any other big number of people, you measure their sodium, their potassium, your chloride, and whatsoever, and whatever falls within 2 to 3 standard deviations of the average, that would be considered normal. And whatever is outside that is considered abnormal. And if you have tubular disorders, then very often your patient will be living outside these average on the very abnormal end. And this again causes these panic calls. And in my now, I don't know, almost 20 years of work with tubular disorders, I've sort of established my own tubular wall of fame, the excess abnormalities that I've encountered. So sodium from 99 was the lowest, although I must admit that wasn't a tubular patient, that was a nephrotic patient, a congenital nephrotic, but 201 in a patient with NDI who was severely dehydrated and also mistreated actually with normal saline. Potassium as low as 1.0, as high as 12.4. Chloride as low as 56, as high as 184. And plasma pH as low as 6.7, dramatic acidosis, and as high as 7.9, incredible alkalosis. So these are the kind of extreme abnormalities that you see in these patients with tubular disorders. And the really astonishing aspect to that is that most of these patients actually walk into your clinic and are alive, something that you would never thought possible. So to what degree is this a problem? So I have thought about that quite a lot recently, and that was prompted by this one case. And that was a young person who had hypokalemia, and I'll come to that in a minute. So is a potassium of 1.8 in someone who's chronically hypokalemic really dangerous? Or is it only dangerous in somebody who used to be at a normal range and then suddenly dropped to 1.8? In general, my teaching is the more extreme the abnormality, the more you can actually relax. You shouldn't panic, you can relax. If somebody is alive with a potassium of 1.0 and is walking into your clinic, the only explanation for that is that this is a chronic disorder that has developed over a long time so that the body could adjust to it. And the last thing you want to do is to change that quickly. And then, of course, there's also the problem with many tubular disorder is that you cannot really correct these abnormalities. The more supplements you provide, the more is coming out in the urine. So I call this the filling a bucket with a slit on the side. You pour it in and it's just coming out as a sort of expensive urine. And that also makes me then wonder, is it really worthwhile trying to give industrial doses of supplements, chasing an elusive normal value when it's pretty much impossible to do so? And patients, I think some of them at least, have also recognized that. I once gave a second opinion on a patient with Bartter syndrome, and this particular patient, in their local hospital, whenever the potassium was less than 3.0, that patient would get admitted, would get IV potassium, bring it up, and then once the potassium was higher, the doctors would tap themselves on the shoulder. Great, we made this patient safe, and send them back home. Obviously completely ignoring that 2 hours later after the IV infusion, the potassium will be down in the boots again. And the parents of this particular patient were quite clever. They had figured out that if they give the supplement roughly half an hour before the blood test, the potassium supplement, then most of the time the potassium would be higher than 3.0. They would not get admitted and they could just go home. So the abnormality in the blood is also highly dependent on how you time it in regards to the last dose of the supplementation. And if you do this as I do for many years and you get all these panic calls, it's very easy also to get jaded and just say, okay, well, yeah, so it's another potassium of 1.5. I've had 10 already today, who cares? But is that really the right attitude? Sorry. And this is the case that made me think about this. So this was a 15-year-old boy. He was previously fit and healthy. There was no complaints. He had normal functioning life. And he presented to his local A&E, so this is English for emergency room, with cervical lymphadenopathy. And they did some routine blood tests, and they saw that he has a potassium of 2.6 and a magnesium of 0.55 millimoles per liter. And so they got their panic value from the lab, and they did the appropriate thing. They panicked. They admitted him, they put an IV in him, and they corrected him intravenously with lots of potassium and magnesium. As doctors, we love to correct abnormalities. And after 2 days, and when you measured shortly enough after the IV infusion, you could measure normal values. And then he was discharged home with some oral potassium and magnesium supplements. But conscientious doctors that they were, they just didn't discharge him. They said, well, come back in a week and we will test again. And of course, he has, again, hypokalemia and hypomagnesemia. And during that time, he is becoming increasingly symptomatic. So he complains of chest pain, he has frequent cramping, he's fatigued, he cannot do any exercise anymore. And then he comes to hospital and they realize, oh, his potassium is low, his magnesium is low. So they increase the supplementation. He's getting more potassium, he's getting more magnesium, until at the end, he's taking more than 50 tablets, more than 50 tablets per day of potassium and magnesium supplements. And despite this industrial amount of tablets that he is supposed to take, he is still incredibly symptomatic. In fact, it's getting worse. He's unable to attend school, and he has a very dramatic fainting episode at home in front of his parents. So they are, of course, extremely worried and bring him back to A&E, where he is seen again with hypokalemia and hypomagnesemia. And we had been contacted by the local hospital during this time and tried to give some advice. And then he had his clinic appointment in our tubular clinic on a Tuesday morning. And I had been actually quite, well, interested to see this boy, where we had so many phone calls and who has been so symptomatic with it. And when he came in, there was a 15-year-old boy, clearly a very bright boy, fully engaged. He listened very carefully. I actually tried to go into some tubular physiology with him. He asked very good questions. When his mom gave the history, he corrected her. He had his laptop there where he took notes and also had some details in there. And he had a normal examination. He had a normal blood pressure. And he had these kind of biochemistries. Actually, not that bad. Potassium 3.3, just borderline low. Borderline low chloride, elevated bicarbonate, low magnesium, hypocalciuria. I mean, this was a textbook case of Gitelman syndrome. Hypokalemic, hypochloremic, metabolic alkalosis with hypomagnesemia and hypocalciuria. That is classic Gitelman syndrome. Sometimes you can also see it with Bartter syndrome type 3. So this would be the main differential diagnosis here, I think. Well, I've went into that. So Gitelman syndrome, and indeed we then did genetic testing. He had compound heterozygous variants in SLC12A3, the underlying gene for Gitelman syndrome. And just to go into a little bit more detail about this, Gitelman syndrome is a salt wasting tubulopathy. So you could say, well, then he should have an increased excretion of sodium. But look at his fractional excretion of sodium, 0.1%. So this is one teaching point I like to make, is that the fractional excretion of sodium is a very poor indicator of a salt wasting tubulopathy. And the reason for that, of course, is that in steady state, the excretion of sodium in the urine must be equal to the intake of sodium. You cannot constantly excrete more sodium in the urine than is coming in. If so, you would die of hypovolemia. So in steady state, what comes out in the urine must be equal to what's coming in. So the first thing I could tell from this is that he certainly did not take his salt supplements, because if he was taking salt supplements, he would have a much higher fractional excretion of urine. But the other thing that I always try to teach is look at the fractional excretion of chloride. That is a much better indicator for a salt wasting tubulopathy. Because one of the things how we compensate for the salt wasting is, for instance, by exchanging sodium for potassium in the collecting duct. You reabsorb sodium through ENaC and you secrete potassium. This is why you get hypokalemic alkalosis in Bartter and Gitelman syndrome, because of this compensatory upregulation of sodium reabsorption in the collecting duct. But whether you excrete sodium or potassium or protons, you always need to have chloride with it. And here, so the chloride fractional excretion of 1%, when we did this review of our own cohort here, all the Gitelman and Bartter patients at presentation had fractional excretions greater than 0.5% for chloride. Okay, that was just a little side show here about the use or not use of fractional excretion of sodium and better use fractional excretion of chloride for the diagnosis of salt wasting disorders. But what now? What about this patient who has this salt wasting tubulopathy and is incredibly symptomatic with it, is already on industrial doses of supplementation, who do not seem to help at all? And this really touches on one of the key problems I think that we have these patients. Some patients with Gitelman syndrome or Bartter syndrome are highly symptomatic, and others have no symptoms at all. There's probably a lot of patients with Gitelman syndrome around us who have never been diagnosed. When you look at the number of pathogenic variants in population databases, then you can estimate that the frequency of Gittelman syndrome is probably something like 1 in 1,000 or 1 in 2,000, much higher than what we expect from the number of patients that we see in our clinic. So there is a good number of Gittelman patients who seem to have no symptoms that ever prompted them to go to a doctor. And yet then we have those other patients who seem to be terribly symptomatic, fatigue, unable to go to school or do a job, and so on. And you cannot tell them apart by the electrolyte values. The electrolyte, the degree of hypokalemia, of hypomagnesia is exactly the same in both cohorts. So the severity of the symptoms is not related to the severity of the electrolyte abnormalities. And in this Gittelman KDIGO consensus paper, one of the things that was most controversially discussed is what ranges of electrolyte levels should we aim for. And I think we wrote in there that we should try to achieve a potassium of 3.0, but especially also the patient representatives in there were quite keen that we said, well, but in some patients, this may not be achievable, because they felt if we write that in there and they will try to give us a potassium of 3.0, we will have to eat hundreds of tablets a day, and it's just not possible to do that. So the usual response for most clinicians, I think, is if we are informed of an abnormal blood value like hypokalemia, we say, okay, well, then we increase the supplements. We have to do something about it, and we can document in the notes, okay, potassium was 2.5, so I doubled the potassium supplements. We do something, we act. And then if you're conscientious, we repeat the blood test later and see, well, did my increase in the supplements help? And of course, the patient is still hypokalemic. Think of this analogy of trying to fill a bucket with a slit on the side. The more you pour in, the more is pouring out. And then we increase the supplements again and again and again and again. And we get into this vicious circle until the patient is on some incredible prescribed amount of tablets that or liquid in smaller children that no patient ever could take in their lifetime. And the real question that I would like to ask you is, do we really treat the patient, or do we just treat a number, a blood level? And just think about that. And this boy was very informative in that regard, because well, he was, first of all, in clinic, he was fully functional. I couldn't see any fatigue, cramps, or anything like that there. His biochemistries actually were quite remarkable. I mean, a potassium of 3.3 in a patient with Gittelman syndrome is incredible. Have hardly ever seen such high potassium in my tubular clinic. And this is, even that is above the KDIGO consensus recommendation for potassium of 3. But the main point that I was trying to make to this boy and his family was, you have had Gittelman syndrome all your life. You were born with this. You have had abnormal electrolytes for years, and you have been living perfectly fine with it. You had no symptoms at all. The symptoms only developed once you knew about it. And he, of course, also, he saw the panic in the eyes of the doctors when they got it. And that really made him anxious about it. And he went on the internet and read about Gittelman syndrome, and he reads about sudden cardiac arrest and that he can die of it. And so when he previously had cramps or fatigue, it was just that. Everybody gets them. Everybody has a cramp. Everybody is sometimes fatigued. Nothing to worry about. But once you have seen this panic and you have read about that this is potentially deathly, that you could die of this, then whenever he had a cramp, now he got terribly anxious because he thought, okay, next step is cardiac arrest and then I'm dead. So I think this is also very typical. It's the context in which we perceive symptoms, which as pediatricians, we are well familiar with. Think of a child that gets a blood test. There are some patients who already worry days before the scheduled blood test and work themselves in such a state and scream and fight. And for them, before the needle even enters the skin, this is already the worst pain they could ever imagine. And then you have a good play therapist with them who can distract them, and I don't even feel that the needle is going in. So the stimulus is the same, a needle going through the skin. But if you're really anxious about it, it's the most terrible pain ever. And if you're relaxed and distracted, you hardly feel it. The same stimulus, completely differently perceived. And I think this is very similar here for these symptoms with Gittelman syndrome. If you have cramps, if you have fatigue, and if you're really worried about it and say, oh gosh, this is just the harbinger of my imminent death. Next thing, I will just have my cardiac arrest. Then, of course, you perceive these symptoms much more seriously as if you're not worried about it. The big question, of course, for me now was how do I deal with that? So I first just try to provide reassurance. I try to tell them that this really is not a lethal disease. Yes, there are some case reports about sudden death in these patients, but this is exceedingly rare. There are thousands of patients with Gittelman syndrome out there. And as I said before, we think that the true frequency of these diseases is actually much higher than the patients that we see in our clinic. So a lot of people are out there living with Gittelman syndrome and have no problems at all. This is not a disease that you are very likely to die of. And after providing that reassurance, I also thought I cannot really tell them, so this is, you're going to be fine. This is not a deadly disease, but you still better take your 50 tablets a day. I didn't think I could do that because that would still give this message. You really, we're still worried about this. So I actually told him to stop all his routine supplements, to stop those 50 tablets that he was taking a day, or was supposedly taking, based on the fractional excretion of sodium that he had. He clearly was not taking, at least not all of them. And instead, I just told them, well, whenever you do get symptoms, if you do get cramps, if you do get fatigue, take some extra sodium. I try to really highlight that Gittelman syndrome is a salt wasting disorder. So the proper treatment is salt and not potassium. So take some extra salt. Take some magnesium if you get cramps, for instance, so that you treat these symptoms acutely, but otherwise try to live a normal life. And I referred him to our psychologist, actually, to help him with his anxiety. And now this was about a year ago. He's still symptomatic. So it's not that he's back to where he was before, but he's back in school. He pretty much has a normal life back. He came from a very health conscious family who was on a very low salt diet. And I had told him, you can eat as much salt as you want. And of course, as a teenager, he really loves to indulge in a high salt diet and eat all the pizza and all the fast food that he can. And as I said, he still has symptoms, but he can manage now and participate fully in school and so on. And this is from his most recent follow-up here. And you can see that the electrolytes, when he was supposedly taking 50 tablets a day, are not that much different to the electrolytes when he was off all supplements. Now, I think what I'm saying here is highly controversial, and I'm fully aware of that. And I don't want to give out the message here that don't worry about potassium for 1.5, it's all going to be fine, don't worry about supplements or so. I also don't want to say that any patient with these disorders who experiences symptoms just has a problem in the head. They clearly have symptoms. They absolutely do. I have no doubt about it. But again, I think it's the context in which they are perceived that is so important about whether these are debilitating symptoms or whether they are symptoms that, yeah, they're there, but I need to deal with them. And I would never argue against never using supplementation. Most of my patients are on supplementation, but I think you have to be able to strike a balance between what is actually tolerable and achievable and to what degree does the patient actually feel better with them, and not chasing some target of some specific number. So in conclusion, treatment of these tubular disorders is challenging because it's almost impossible to ever get normal electrolytes in them. When you have these tubulopathies, the blood results are often at the very extreme end of the spectrum. Again, think of this bell curve that I showed you before. They're often at the very outsides of it. But I don't think that you can ever give a specific threshold where you say, below this, it's fine, above this, it's dangerous, or the other way around. So a potassium of 3 is fine, but a potassium of 2.9 is dangerous. It is, I think, very much depends on whether it's chronic, if the patients get used to it. And what I strongly believe that also is that it's actually safer to have a chronically low value, let's say potassium of 2.2 or something, rather than giving a big intermittent dose of potassium so that it goes up to 5, and then because of the urinary losses within an hour or two it's down back to 2.2, and then you give another big dose and it's up to 5. So I think that these wildly swinging values are probably, but this is purely speculative, this is purely my opinion, there is no evidence for it, but I do believe that these wildly swinging potassium or magnesium or whatever values are actually more dangerous than a chronically low value. And we always should aim to treat the patient and the symptoms of the patient and not some kind of elusive target value. And I'm pretty sure that this will generate some lively discussion because I'm fully aware that this is very controversial, what I'm saying. So over to everybody for questions.
Thank you, Professor Buckenhall, for that very
stimulating
around tubular diseases and what problems we face in our clinics. And you really took care of one of my questions, which we, as one of our fellows had brought up, that how much should we react to the potassium levels when we see them in the clinics? In asymptomatic children, potassium running between 2 to 2.5 millimoles per liter in many of our tubulopathy patients. So that is taken care of. I was trying to look at the question and answer box, and while we await some questions, maybe I'll start off with one. So when you are evaluating your patients with renal tubular acidosis, how often do you really rely on the core biochemical tests recommended, such as urine anion gap, U minus B carbon dioxide, urine minus blood gradient for carbon dioxide, the bicarbonate loading test, and say an acidification test such as fludrocortisone furosemide test? How often would you be employing these? Would you do them all?
Virtually never. I think the advantage of being a pediatric nephrologist, of course, also is that we pretty much only see the inherited distal tubular acidosis. In the adults, they have all the acquired ones, intermediate ones. It's a little bit more tricky, but in children, the diagnosis is usually so barn door obvious. You have a child with failure to thrive, who comes in and has a hypokalemic acidosis and has a urine pH that is typically 7, 7.5, 8, so clearly inappropriate. If you're acidotic, you want your kidneys to excrete an acid urine to get rid of the acid. And if the urine pH is 7 or something like that, then this is clearly inappropriate. And that is the diagnosis. There is very little an additional test that you need. So I hardly ever do. I think I have in my lifetime once done a urinary acidification test using furosemide and fludrocortisone. And that was in a patient with a very intermediate phenotype. And so I try to define it better.
Yeah. So would you agree that you would need to employ the fludrocortisone furosemide test or another such test for a patient with a partial or an incomplete phenotype wherein you have
Yeah, that's
maybe
what
a
I
stone
tried to
former,
do. Yeah.
a stone former? Would you evaluate all your hypercalciuric nephrolithiasis patients with it, for example?
No.
No.
First of all, also, I think if you have somebody who comes in with a urine pH of 5,
Yeah. No need.
there's
Yeah.
no
That's
need.
just the
Yeah.
best
And
screening too. Yeah.
and if their plasma bicarbonate level is well in the normal range, I would also not worry. But this is my personal practice.
Very
Again, this is
experienced opinion. Yeah.
yeah,
After
but
doing loads
maybe I'm
and
missing lots of
family events. No, you wouldn't.
incomplete distal RTA because I'm just not looking. So I don't want to say this is the gospel, but in my own practice, I really hardly ever do it.
Okay, so I can see that the question and answers have come in, and what you have spoken about has generated a lot of
I can imagine.
questions. So we have 3 questions fairly about the same aspect. How much is the average safe value in your experience? I suppose that refers to the serum potassium. Another question is, how about chronic hypokalemia causing polyuria, cysts, and maybe interstitial nephropathy? And another one is an asymptomatic gentleman walks in with serum potassium chronically between 2 and 2.5 millimoles per liter, but has ECG changes in the ST&T wave segment. So would you still not need to chase the number?
So the first question, I think, is the easiest to answer because it's just, I don't know. And my point that I was trying to make is I don't think there is a universally accepted safe value. If you get the potassium about 2.345, then you will be safe. But if it's 2.3, then it will be unsafe. So I don't think you can make these clear distinction. Life would be so easy if we could do that. Now we just need to aim for 2.4 and we will be fine. But it's not like that. I think, again, it's for each individual patient. So there are some patients who, especially Barta3, they're usually the worst ones. They have the most severe electrolyte abnormalities, and this potassium of 1.0, for instance, that I had in my clinic as the lowest that I've ever experienced, is in a patient with with Barta3, and they often have potassium values in below 2. And then I also get anxious. Yeah, this is quite low, but it's not because I know that having a potassium below 2 is dangerous, whereas if I could have 2.1, it's fine. It's just because it's so extremely abnormal, and we have been all trained to reach for these normal values, that the more extremely abnormal it is, the more anxious you get. But do they really have a problem with that? I don't know. I've never in my clinic had that. What was the second question? You're muted. You're muted.
Sorry, I'm sorry. Chronic hypokalemia, polyuria, cysts, and maybe interstitial nephropathy.
So does chronic hypokalemia cause a urinary concentrating defect? Does it cause cysts? Does it cause interstitial nephritis? I personally very much doubt that. And I think Gittelman patients are the best example for that. Show me a Gittelman patient with a urinary concentrating defect. If you check the urine osmolality in clinic, it's typically 800, 900. They usually have very high urine osmolalities. They're chronically hypokalemic, but they can beautifully concentrate the urine. Show me a Gittelman patient who has a cyst. Can you remember a single Gittelman patient in your clinic with a cyst? I can't. So they have chronic hypokalemia, but they don't have cysts. And do they get chronic interstitial nephritis? Do they get chronic kidney disease? I have not seen that. So does hypokalemia really cause this? I very much doubt it. Typically, these complications are associated with hypercalciuric disorders. So cysts common in hypercalciuric disorders. And if you take distal RTA, if you take Bartter syndrome type 1 and 2, these are disorders that have both hypokalemia and hypercalciuria. So I think those issues get conflated. I personally often think that it's the hypercalciuria, which then leads to obstruction of individual collecting ducts, and then you get cystic dilatation of the nephron proximal to it. That's my personal speculation. I don't know, but I very, very, very much doubt that it's the hypokalemia that's causing these abnormalities.
Detlef, we had a 12-year-old boy walk into us with a diagnosis of cystic kidney diseases, referred to us for evaluation. And, we sent out a next generation sequencing panel and they couldn't find anything wrong with the cystic kidney disease genes. And we looked again and again. And no, he turned out to be a gentleman. He did.
Okay.
He did have hypomagnesemia, hypokalemia, and therefore I would slightly differ here because he does have loads of cysts, and maybe we will share the images and the report with you separately.
Well,
yeah, but we do
sooner
have
or
one,
later,
one
sooner or later, you will find a Gittleman patient who also has a cystic kidney disorder. If the frequency of this disorder is 1 in 1,000, you will have some who have both disorders. But if you think of, I mean, I don't know, I have maybe 30 Gittleman patients in my practice, so we all have relatively small numbers. I cannot think of a single one who has cysts. And yes, if you have one who also has lots of cysts, well, then maybe he has 2 disorders. And how often, it's very common that you have a cystic disorder without being able to identify an underlying genetic defect, I think.
Agreed. Yeah.
But I certainly had patients coming, refer to me for cystic disorder, and they had distal RTA, for instance. So very common to have cysts in distal RTA.
And while on that, would you want to expound on why that's with the calcium excretion abnormalities you would suggest that's the reason why?
So this is my speculation that maybe it's, there are very few reports of biopsy reports in hypercalciuric disorders, and you always have the intraluminal calcium deposition. So maybe at some point you actually get obstruction of that particular collecting duct. And so then you have a glomerulus that's still filtering and yet cystic dilatation. I don't know. I really don't know. But that's one of my ideas. And it's typically medullary cysts that you see in these disorders. So collecting ducts there would be quite fitting.
So the third question was in relation to ECG changes being present at a modest level of hypokalemia.
You do see these ECG changes. You do see it quite frequently. To what degree is it dangerous? There are reports out there, especially from the Italian group, I think, where they have also said they just interviewed pediatric nephrologists and said, can you remember anyone who had Bartter-Gittleman syndrome and suddenly died? And there was quite a number of cases that they could recall. So I don't want to poo-poo this, that these are all benign disorders. There clearly are these complications. They typically occur in the context of gastrointestinal disease. So if you have a salt wasting disorder like Bartter-Gittleman syndrome, and then you have additional salt wasting, for instance, from diarrhea, this is when you're really at risk. This is when your potassium is typically the lowest, but the one thing that you typically cannot measure is your volume status. And I do wonder if it's actually the hypokalemia that kills these patients, or is it just severe hypovolemia because of the salt losses? And you cannot measure volume as easily as you can do potassium. So nobody knows what the volume status in these patients is, but because of these incredible salt losses, they are, of course, at high risk of hypovolemic shock. So if somebody has ECG changes, I probably would try to improve this, but again, give them potassium supplements. I very much doubt that you will be able to actually change their ECG, or maybe you change it for half an hour while you just absorb the potassium, but an hour later it's abnormal again. So I think some of this jadedness that I have about these abnormal values is also because of the frustration that you actually cannot really normalize these values, at least not with enteral supplementation.
Yeah. So we have another question on the chat window, which says, how does diet influence the level of electrolytes in Gitelman syndrome?
Yeah, that's a very interesting question. Gitelman syndrome actually is very special, I think, in that regard, in that it's a salt wasting disorder, and the hypokalemic alkalosis is a purely physiologic response to the salt wasting. In Bartter syndrome, it's slightly different because Bartter syndrome involves the macula densa. So this tubular glomerular feedback is short-circuited and doesn't work properly. But in Gitelman syndrome, macula densa is intact. So the renin-aldosterone production is purely mediated by the hypovolemia that these patients experience because of the salt wasting. So you can treat their potassium by giving them salt. The more salt you give them, the more you expand the intravascular volume, the less renin-aldosterone they will produce. So, and if you talk to any Gitelman patients, also Bartter patients, they will all tell you that they crave salt. They have sometimes very peculiar eating habits. Martin Conrad once did a poster where he collected these various habits. I mean, there were patients who were licking the salt off the street in the winter. They were, what I have in many patients is that they like gherkins, these cucumbers in salty vinegar. They drink the whole jar. They eat them and drink the whole jar. Sometimes I find this is diagnostic. If a patient comes and tells me, "Oh yeah, I love these gherkins and I have a jar a day," I say, "You have Gitelman syndrome." So they crave these salty foods, and I very much encourage them to indulge in that. So I say, usually the doctor always tells you, you must not eat salt, it's bad for you. But for you, it's actually the opposite. You should eat as much salt as possible. And that will improve their potassium levels because you suppress the renin-aldosterone response.
Okay, thank you. That's instructive. So there's another question about how to manage, and I assume antenatally detected or presenting Bartter syndrome baby with severe polyuria and severe failure to thrive. What would be your principles of managing?
Yeah, they are always challenging. In these patients, what usually is very helpful is non-steroidals, but you're of course also very reluctant to use non-steroidal in these patients because of the fear of necrotizing enterocolitis and gut problems. So typically we try to avoid that in the first couple of months at least. But if we are really struggling with the polyuria and we really have difficulties keeping up with the fluid, then I try it. And there are even reports of that being tried antenatally, giving to the mother in order to reduce the polyhydramnios. And we typically would use then one of these more selective COX-2 inhibitors, or one of them. The only one available, I think, right now is celecoxib. So in order to minimize the risk of gastrointestinal side effects.
Okay, so that's that. I am looking for, I think we have dealt with some of these questions. Do we have time for more? So I think we do. So do you, what would be the current consensus on evaluating using the transtubular potassium gradient? Would you be using the TTKG in evaluating patients with, say, hyperkalemia very often?
Yeah, I think that is helpful in assessing what is the renal response. I mean, usually in hypokalemia, if you have a very high TTKG, well, that will tell you it's the kidneys. You're losing the potassium via the kidneys. And in opposite, in hyperkalemia, you would want to have the kidneys a very high TTKG. You would want them to excrete as much potassium as possible. And yet, if it is low, then you know, okay, this is a defect in the distal tubular potassium secretion. So I do use the TTKG. You can also use the fractional excretion of potassium. As a pure physiologist, you are never supposed to use fractional excretion of potassium, because you're only supposed to use fractional excretion for substances that are filtered and reabsorbed, whereas potassium can be reabsorbed and secreted. So you can have fractional excretions that are higher than 100%, which of course is against the concept of the fractional reabsorption. But in clinical practice, in my experience, fractional reabsorption works just as well as the TTKG. The TTKG was developed to specifically assess the potassium secretion in the collecting duct. And the idea behind is that the only way potassium concentration there can change is either because of secretion into the duct or because of extraction of water. So that's why you correct for the osmolality. But you're only supposed to use it if the osmolality of the urine is at least 300 or higher. And in especially these Barter patients, very often lower. So there is physiological purity and there's clinical practice. And I think that it works usually in clinical practice quite well, whether you use TTKG or whether you use the fractional excretion.
Okay. So while on physiology, there's a question around why is the concept of tubular maximum only applied to phosphorus and not to other solutes, say sodium, potassium, calcium?
Yeah, so that's a good question. First of all, you can use that again only for substances that are filtered and reabsorbed. You cannot use it for substances that are secreted. But we would talk, for instance, about the threshold for bicarbonate. So if you have a patient with proximal tubular acidosis and you have a bicarbonate of 10, then you know that's the threshold. That's where the proximal tubule can still keep up with. As soon as you go above 10, the tubule will spill out the excess bicarbonate, but below that it can cope. So you can apply it to other substances, but again, it is only for substances that are purely filtered and reabsorbed. And this is, I think, also why it's not such a concept with the bicarbonate, because bicarbonate is then also affected by the buffering of acid. So bicarbonate can decrease not only because of less reabsorption, but also because of increased acid that is then buffered by bicarbonate. Okay. Sugar would be another one. Yes. But again, there's so much variability because of insulin and the sugar level that it's very difficult to say what exactly is now the tubular component to it and what is the endocrinal component to it.
Yeah. So while on physiology, while on potassium still, have you had a chance to use any of the newer anti-hyperkalemia drugs like zirconium or patiromer? And have you had occasion to use them in
So I have not. I think this is much more common in patients with chronic kidney disease. So my colleague Oksana Shroff sometimes uses zirconium. I personally am still the one patients where I use these potassium binders is the PHA1, pseudohypoaldosteronism type 1. The ones with the severe ones with ENaC, and where you give them, but I give them sodium resonium, because I really like the idea of using the colon as your distal tubule, where you're providing sodium in exchange for potassium. And that works very well. So I have never felt the need to switch over to one of these newer ones. But that makes me just old-fashioned and old, I suppose.
No, so while on PHAs, is there a safe threshold of high potassium there as well that we choose to accept similarly as you would for hypokalemias?
No, I think, but I don't think that is a question that arises so much, because I mean they certainly surprise you. The potassium of 12.2, the highest that I've experienced, is in a patient with PHA1. I don't want to say that patient walked into my clinic. It was severely ill patient, but it was severely ill. I don't think because of the potassium of 12, but because he was in hypovolemic shock because of the salt losses. And the first thing you always do for these patients is just give them saline, saline, saline. You just pour volume into them. And as you expand the intravascular volume, just by dilution, the potassium comes down and everybody can breathe a little bit more. And then when you provide them with bicarbonate, the potassium comes down further and so on. But in the long term, you can treat the potassium in these patients beautifully. You give them the salt supplements, the bicarbonate supplements, and then the resonium. So it's completely different to Gittleman and Bartter syndrome, where you can give industrial doses of potassium supplements and they're still hypokalemic. Here, you can treat it. So I don't have the problem that I say, do I accept 7.5 or 7.4 or 7.7? No, I can bring it down in the normal range. It's not a problem. You're mute again. You're mute.
Sorry again. So moving on to one of the more recently described causes of the Bartter phenotype, the MAGED2. So
Yes.
why is it really only transient and only seen in the antenatal period?
No, well, I don't think anybody knows. I mean, this seems to be a gene that is expressed during the developing kidney and seems to regulate these tubular transporters, including NKCC2 and NCC. And it doesn't seem to be expressed later on. At least that's how I understand it. I'm not sure if I'm really saying accurate things here. So, but why is that? I don't think anybody knows. I mean, this is one of these typical miracles of genetics to give the completely unexpected answers. I always see these people who do looking for candidate genes, and this would be a good one. But the beauty of genetics is that it can give you the completely unexpected. And MAGED2 is clearly one of those things where you had something completely unexpected. And you can imagine how much head scratching had been going on by the group when they discovered this gene. So how do we explain that? How do we publish that? How do we actually make a story out of this? Because it is so completely unexpected.
Yeah. So there's another question with me here. I don't see too many coming in now on the chat box here, but these are some of my fellows that are posing questions to you. So another one they've asked me to ask you is, why is there no known tubulopathy phenotype associated with NKCC1 when you have one with NKCC2? You know, the NKCC1 would be having a role in the tubular glomerular feedback, but
I don't think NKCC1 is prominently expressed in the tubule. NKCC1 is in the inner ear, as far as I know.
okay.
But I don't think there is significant expression in the tubule.
Okay.
Again, I'm not on 100% safe ground here, but I really don't think there's significant expression of NKCC1 in the tubule.
Okay. You know, sometimes, you know, we have too much information at our hands, you know, when we have next-gen sequencing so easy to order and, you know, use. So, I mean, suppose a family with Gittleman syndrome, a child with Gittleman syndrome asks about prenatal testing. How would you respond to that? Because, you know, the condition being chronic, it is not typically disabling or debilitating on the long run. How would you respond to that?
This is a very difficult ethical question. I think I have taken up the British attitude towards that, and that is that people should make their own choices, and we as doctors can provide information, but we should not tell them what's right or wrong. So I have not come across it with Gittleman syndrome, but I had a patient with distal RTA with inner ear deafness, so the ATP6V1B1, and where the mother said, I want a prenatal genetic diagnosis. And I provided her with the information. I mean, I obviously, for me, distal RTA is an eminently treatable disorder. They have a normal life, but obviously here was the inner ear deafness. So, but I provided her with the information, and she had actually then a pre-implantation genetic diagnosis and had a pregnancy with an unaffected child. So, and I think I would provide the information to the Gittelman syndrome. I would probably make some remarks about how I think that this is actually quite a benign disorder, and whether this is truly something you would want to consider, think carefully. I have not had that question from Gittelman families, but I would also not try to be paternalistic and tell them this is not the right thing to do. I would provide them, I think, with the information, but perhaps subconsciously some of my bias would come out in that communication.
Indeed. Yeah, so we had a similar kind of a situation, and yeah, we differed in our opinions and how we conveyed it to the family, I guess. Probably we would take just one more question. I mean, what's been your experience with transplantation for tubular disorders? I'm sure a fair bit of cystinosis, maybe. Anything else?
Yeah, cystinosis
Any
obviously is in a way a poor example because it's a systemic disorder. It's not just a tubular disorder, but of course the tubular aspect, the kidney aspect, is cured, and that would be true pretty much for all those tubular disorders. You put a new kidney with the correct genetic instruction, and the disorder is cured. But especially if you think of disorders like distal RTA, Gittelman, that are either relatively mild or relatively treatable, you do have to ask yourself if the solution, meaning a graft with a limited lifetime, the need for constant immunosuppression, is actually better than the disorder that you're trying to treat. What I'm constantly trying to do is there's all these startup companies now springing up that are providing genetic treatment. And I always try to convince them that the tubular disorders are the ideal target, because if you do nephrotic syndrome, for instance, let's say congenital nephrotic syndrome, you develop a treatment for it. Well, by the time you provide it, the kidney is probably already in end stage. You treat a kidney that has already been scarred. But with these tubular disorders, if you can provide the genetic instruction, the patient is cured. The kidney otherwise functions completely normal. So hopefully that will become available in the next, I think, 5 to 10 years. And I would be actually quite optimistic that that's the case. And then it's time for me to retire because I have nothing to do anymore.
But what will be the repertoire of diagnoses that you see? If you encounter in your clinic, you would hardly have any chronic kidney diseases, right? I mean, you would have cystinosis, and you would have maybe a few distal RTA and a few Bartter, and maybe the familial hypercalciuric hypomagnesemic patients. That would be the
then Gittelman, right? And then a lot of NDI.
The ones progressed. The ones who progressed to advanced kidney disease.
I'll see if with regards with chronic kidney disease. So that would be very few. But of course, the familial hypomagnesemia with hypercalciuria and nephrocalcinosis, they clearly would be the ones who progress. And then a few with dent disease, Lowe syndrome, who will progress.
Okay, thank you. That's been very, very enriching, this discussion. I think you've done spectacularly well on this interview that I took of yours, and on behalf of all our fellows and all the participants, thank you so much. It's been wonderful having you here. And with that, I hand over my responsibility and charge to Kalaivani. Thank you, Professor Buchenhor. Thank you.
You're very welcome. Thank you for having me.
Hope you don't mind staying for the next 10 or 15 minutes, because we'll be announcing the winners of the polling session.
Okay.
Amrish, do you have any questions for Dr. Detlef?
No, this was an excellent talk, and thank you so much, Dr. Detlef, for sharing all your experience. And I really liked your Tubular Hall of Fame slide. I think that's very, very impressive. I think those are some tough numbers that you have dealt with. So thank you so
Yeah,
much.
but again, usually my advice to the fellows is the more extreme, the more you can relax. If a patient is alive with those numbers, it must have been chronic. It must have been developing over a long time. Although perhaps a potassium of 12.2 is still something where you want to do something quickly, and that is saline into the patient. But okay, I'll leave it there.
Yeah, no, thank you for, that excellent message. And thank you, Dr. Sinha, for, conducting this session so nicely and for all your questions. I think that generated a lot of discussion. And I'll hand over to you, Dr. Kalavani.
Yeah, we had this session of tubular webinar series from July 9th to August 24th, and we had totally 6 polling sessions, and we also have cash rewards for it. And so we have the first winner. It's our own fellow, who's Dr. Arpita KR. She is ISPN trainee from our own institute, Dr. Manitas Hospitals. Dr. Arpita, can you share your experience? Can you share a few words on your experience on this session?
Yes, ma'am. Thank you. Good evening, everyone. It's really a privilege to receive this award from an amazing webmaster series platform. I would like to congratulate Dr. Kalaivani and Dr. Amrish sir for conducting this session such beautifully. And it was a pleasure to hear from such eminent speakers in pediatric nephrology across the globe. And like tubular disorders are really the subject is very evaporative, I feel. So you need gradual, constant attention and repeated reading, and to understand concepts is very important. So this webinar series really helped us to do that and clear all concepts and many of our doubts. So I would like to extend my regards to Dr. Kalaivani and Dr. Amrish for conducting such a wonderful series. And I would also like to give my gratitude to my mentors in Mehta Hospital, Dr. Namalwar sir, Dr. Edwin, Dr. Kalaivani, Dr. Sukanya, and Dr. Sudha, and my co-fellows, Dr. Sunil and Pooja. And I congratulate the other winners also and all who have participated in this webinar series. Thank you.
Thank you so much, Dr. Arpita. And the next winner is the second place goes to Aishwarya. She is a pediatrician from Stanley Medical College. Dr. Aishwarya, are you there? We would like to hear a few words from you.
Yes. Good evening, everyone. I'm Dr. Aishwarya from Institute of Social Pediatrics, Stanley Medical College. I would like to thank all the members and the coordinators of this very special program that has been happening since July 2022. We all have learned a lot from these sessions, which we will also learn retrospectively also from all the YouTube videos which has been uploaded. And I would like to thank especially my HOD ma'am, Dr. Rema ma'am, Dr. Ganesh sir, Dr. Egampranath sir, Dr. Subhashri ma'am, who has been constantly supporting to watch these sessions and showing us that such sessions are there. And I also like to thank Dr. Thangavelu sir, Dr. Edwin sir, and Dr. Georgie sir, from whom we have learned a lot of lessons. And I have also learned 2 life lessons, that is simplicity and humility from all the speakers in all these sessions, and also that the real act of intelligence is just to simplify everything than to make it more complex. So I have learned all that, and I wish this happens next year also, and will definitely follow it up next year also, and keep learning from all these sessions. Thank you, ma'am.
Thank you so much, Dr. Aishwarya. It was really nice. We'll keep up your words. We'll be having the next webinar series for the next year, 2023 as well. So the third place goes to Dr. Vedika Bhatt. She's a fellow in nephrology at Indira Gandhi Institute of Child Health, Bangalore. Dr. Vedika Bhatt, would you like to share a few words?
Good evening, ma'am. I'm very overwhelmed by receiving this award. Actually, I got to know about the web series from my teachers, Dr. Alka ma'am and Dr. Hamza ma'am. And I'm just exam going in the next month, and the symposium, this web series came like a boon to me, because tubular disorders have always been a very confusing topic, and there's always so many questions, and there's an endless questions. And when I went through all the topics by the eminent teachers on this web series, I got to clear a lot of my doubts, and the quest was like partially satisfied because it came from experts in the field of nephrology. I thank Dr. Kalaivani ma'am, Dr. Amrish sir for giving us the opportunity through this web series to learn so much about tubular disorders. And through this digital platform, I also got to witness some of the great teachers like Dr. Namalwar sir and Dr. Thangavelu sir, probably through the digital platform, because we have been reading their content, their textbooks. We have always seek their guidance whenever we are in doubt. And through this platform, I got to see this teachers. I was so overwhelmed. So I thank all the teachers who have taught me through this platform. And I would definitely be a part of all the rest of the web series because they are very enriching. Thank you, ma'am.
Thank you, Dr. Vedika. Dr. Detlef, Dr. Amrish, Dr. Aditi, Namalva, do you have anything to add? Would you like to congratulate them?
Absolutely. Well done. I don't know what you did actually to win.
It was a polling session, which was a multiple choice question. So they were.
Done.
Hello.
I'm glad you have an interest in tubular disorder.
I think
Yes.
congratulations, 3 young ladies. It's fascinating to see the whole, all the 3 of them are ladies and the men are yet to follow them. And what my request is, please continue with this pediatric nephrology. It does not stop here. You have a lot to go through it, and each one of you can contribute to the, not only to the subject, but to the welfare of the patients. Each one of you trained, you can save a lot of patients, their troubles, their pains. At least for that, you can take it up. Okay, congratulations. God bless all of you.
Amrish, you want to tell something?
Yeah, congratulations to all the winners. I think this has been a great, polling session. Dr. Kalavani had put in some really, really tough questions. So you should be really, really proud of yourself that you have done so well. And as you can see, there have been lots of participants, and answering those questions was tough. And I really hope that these symposiums has helped you increase your knowledge, both, theoretically, but most importantly, clinically. As we heard the clinical pearls from Dr. Detlef today, I think those clinical pearls from all the speakers, if you can apply to them in the future and take the pediatric nephrology field forward, I think that would be a blessing. I hope, you would be great clinicians and, great researchers one day. So good luck to all of you and congratulations.
I request Namalva sir to deliver the vote of thanks. Namalva sir, you're there?
Yeah, I'm there. Ma. I'm there.
Sir, can you switch on your yeah.
My dear friends, I'm deeply honored to deliver this vote of thanks. Thank you, Dr. Kalivani, for this. To begin with, on behalf of the organizing committee of this Webmaster Series 2022 on kidney tubular disorders, which covered a whopping 23 topics, we thank 86 countries, 42 cities, 989 organizations, and 1,232 individual attendees who were with us from 9th July to today. These numbers portrays the popularity of the third webinar, a continuum of the first 2. To whom this success is due to each of the international and national faculty who magnanimously contributed their previous precious time, space in their daily commitment, and finally a liberal share of their knowledge. We thank each one of them individually. Forgive us for a failure to thank you individually. But to whom does the laurels of this success should go to? It's Dr. Amrish Jain, who the course director, who sat through all the days for every topic from end to end, and was a source of guidance and support to Dr. Kalivani and ourselves. We thank you very much, sir, for all your help and your guidance. And we also look forward to your future guidance and help in the future. The next we have to thank the Department of Pediatric Nephrology, led by Dr. Tangavelu, who was a great support behind Dr. Kalevani. And he's a born teacher and who lives as a teacher and is always ready to help anyone who needs academic help. I thank him and his colleagues for their personal help. The next thing is the staff, our own friends of the Department of Pediatric Nephrology were always a source of support to Dr. Kalevani. To the hospital administration, led by Dr. Praveen, etc., we thank them for their permission and their support and their other good wishes to conduct this seminars. And next is the hospital staff, nursing staff, the administration staff, and the other departments who stood by us, supporting us in helping to conduct this webinar program. And last but not least, I must thank these 3 young ladies who participated in the symposium and who participated in this examination and won for themselves. I'm a little jealous about that because there was all the 3 of them are men and we are women, and we seem to be a little other losing side. Last but not the least, I thank all our friends who stood by us for the help. On behalf of my friends, thank you very much. Dr. Kalevani, did I leave off anyone? Did I miss someone?
No, sir, you had thanked almost everyone,
Okay.
sir. Thank you so much, sir.
Okay.
Thank you so much, sir. It was
Dr.
like,
Namalwar, sir, we want to actually thank you personally because you have been an inspiration for all of us. And you have trained, generations of pediatric nephrologists over the years. And for you to be here for each and every session and give us the guiding light, I think it has been a blessing for all of us. So we really, really appreciate, all your support, all your guidance in conducting these seminars. And we still cherish all, it's an honor to be part of this platform along with you. So thank you so much for all your time, all your help.
Thank you, Dr. Amarish Jain. Thank you very much.
it was really a wonderful experience conducting these webinar sessions. It is actually good to teach and more good to even learn as well. And I had the opportunity to do both. I should actually thank, as Namalwar sir said, a big thanks to all the faculties who had been the real strength of this program. And a big thanks to all the attendees for their consistent participation, and to know that they were, I'm actually glad that they were glued till the end of the program. And it goes without saying that ITNA needs to be thanked for the funding the whole webinar series. Thank you so much for all the support. Thank you so much, Dr. Detlef, for having you here. Thank you so much. We had a wonderful day and a wonderful discussion as well. And it's nice to always hear from experts. Thank you, Dr. Amrish. Thank you so much, Namalwar sir. He is a real teacher who has been staying with us throughout, supporting us, giving us all the guidance for our progress. Thank you so much, sir. Thank you, Dr. Aditi, for moderating the session. Thank you so much. So we'll all catch up next year with a different topic for the webinar series. Thank you, Dr. Detlef.
Thank you.
Thank you. Thank you
Thank
for
you,
the
everyone.
opportunity to participate.
Thank you.
Bye.
Looking forward to next year.
Yeah.
Bye-bye.
Thank you, Amarish Jain. Thank you.
Bye.
God bless you.
Thank you, Dr. Aditi. Bye-bye.
Thank you. Bye-bye.